Thank you very much. Namaskar, good evening. Honorable Lieutenant Governor of Delhi, Shri Vinay Kumar Saxena ji, Dr. Rajiv Behel, Secretary DHR and DG ICMR, Dr. Shiv Sarin ji, President NAMS, Dr. Dikambar Behra ji, President-elect NAMS, past presidents, fellows, distinguished colleagues, presidents, future leaders, and colleagues. I'm honored to be here on a day of celebration of this great institution, great academy, an academy which has a unique legacy, a profound legacy, more than that of any other academy in medical sciences that I know of. This academy, sir, is different because it encompasses all the disciplines of medical sciences. That's the profoundness of this group, this association, and that also imposes then not only to feel glorified in that, but also to perform all across the health sector of India in all the specialties and all aspects of healthcare and healthcare system. I'm very honored and very pleased that we have seen a huge transformation under the leadership of Dr. Shiv Sarin. The initiatives that he listed are amazing. There must have been occasions in the journey, in the history of this institution, when NAMS moved from one state to another. But this journey of 22 to 24 that you steered, sir, was actually much needed, because I think there were issues where the energy levels and the amount of work that we could do, we were not doing. So truly has been an inflection point, and it's difficult to say which area you have not covered in the 10 points that you listed. So big hand to Dr. Sarin and the leadership. Thank you for doing this for India, sir. Thank you. The associations or academies in our sphere have 4 functions, and they all emanate from promoting excellence in the sphere that we are dedicated to. But the 4 functions comprise promoting science and art of education, teaching, capacity development. So this is the first bucket, and we heard a great deal having been initiated and built upon. The second is to celebrate new knowledge, research, innovation, and so on. We should think about how we can be catalyst even more in that regard. The third is policy and advocacy, or advocacy for policy and for change. And I think stellar work has been done through task forces, and we're very proud. The fourth opportunity that we all have is direct reach to the people, to the stakeholders, in terms of health per se, in a broad sense. And one example of that could be indeed the transitioning into the non-communicable disease onslaught that we have. How can this be stemmed? And there, the voice of NAMS directly to people could perhaps be forceful, and there could be other ways of assisting. So I think there's a scope for reaching out directly to people for issues that matter. And you collectively, we all have done, let's say during COVID, but say for mental health, non-communicable diseases, better lifestyle, blending, traditional medicine but reaching out to people is one area that Dr. Digambar Jain, you may like to focus on. So these are the 4 functions, but you can see a huge portfolio of activities, initiatives have been crafted by the National Academy. Sir, I take this opportunity to briefly bring about 3 points for kind consideration of the Academy. First, NAMS has taken an initiative in teaching in multiple ways, the emeritus professor system and then the reaching out to postgraduate system. My request is, additionally, please consider to do this in a formalized manner to support the DNB programs. And DNB programs are so important for our nation's journey to create workforce, a specialty workforce that we all should put our weight and a time behind if possible. The reason is very simple. Postgraduate seats have been more than doubled. From about 32,000 seats, we are above 70,000 seats. And this momentum is being maintained because there has been a severe deficit for specialty workforce. If the overall workforce is 1 per 1,000 WHO norm, and as a developed nation, we are pitching to move to 3 per 1,000. We already were at about 1, and with Ayush workforce, we are 1.4. But when you look at the gradient for specialties, for most specialties, the gradient is where we need 3 to 4, we have 1 specialist. That gradient difference is much more acute, and business as usual for several specialties, even to reach not the developed nations, but one level below that, would take 25 years, 23 years, 79 years for some specialties. Someday we can talk more about it. We need to bridge this because this nation expects specialty care. Now, in the NMC-driven medical college system, huge improvements have taken place. Infrastructure has been built. This takes time to build up medical college. Then a few seats are created, some more specialties are created, and so on. That journey will go on. But at the same time, we have 7 lakh beds in the private sector, and all are teaching beds potentially. The other 7 lakh are being used for the work anyway to have, 72,000 minus 12,000, seats. But from these 7 lakh, we only have 12 to 13,000 seats. Each bed, sir, potentially is a teaching bed. What you need is one person 8 years PG after MD and another person 5-year MD. And you can start teaching them formally and lead them up to degree, and 2 seats are given. This is a potential that exists in Delhi hospitals, sir. Under your guidance, this is one area which I have earlier also discussed with you, sir. But then I'm now reaching out to all of you to please support DNB programs. Don't say poor quality, this, that, secondary. No, make it the best way of doing it. PG training is apprenticeship. This is how it happens in UK, for example, which we often draw example of. So I urge that formally make it a part of DNB system so that the postgraduate DNB students across the territory and more, and there could be many cells doing this, are embraced into this. They all come, they study, and it's more about practical training. It's not about theoretical training. That's possible because it's hands-on that makes a difference, and wonderful teachers can contribute. So the first suggestion is mainstream it with the DNB system. We can work for an MOU with the National Academy. In any case, that originated here, the NBE system. So that's my first suggestion. So the second wave of task forces that you may consider, advocacy for policy, would be one on quality of care. Time has come for India that we need to move to world-class standards of hospital, clinical care, of course, also primary care for that matter. There is a huge gap between where we want to be and where we are today. In our journey toward 2047, as a developed nation, quantity is fine. We are progressing with this, but then quality is now the need of the hour. The Honorable Prime Minister has emphasized this aspect repeatedly, that time for quality as we move forward, and we need it. So how can we improve systematical quality of our hospitals, district hospitals, of medical colleges, AMSs for that matter, private hospitals? What is the accountability framework? Static standards, NABH. How many government hospitals are NABH accredited? You can't even count them in one place. So it must happen. Optimum human resources, optimum systems, accountability, outcomes. So quality of care in its entirety, the vision could come from this exalted body. Number 2, please contribute towards the control and amelioration of antimicrobial resistance. It's a cause that we all should be a part of. It cannot be done only by research agencies. It cannot be done by creating vaccines alone, for that matter, or medicines. We have to change. We have to bring about a change in our way of practicing apart from everything else, which means we create a culture of being responsible users of antibiotics. That's about the profession. And then there are systematic things that need to be done by way of promoting antimicrobial stewardship. so that the antibiotics are used and released on the basis of an objective criteria and not on the basis of my whims or fancies, whether it is private sector or the government sector. So I think bringing together the profession for AMR, which is a silent pandemic, which might chip off a huge part of our GDP as we move forward. We are told that by 2050, this would be the commonest cause of mortality, exceeding cancer mortality and NCD mortality. And the country is seeing very little progress on the scale for this purpose. And fortunately, we are developing National Action Plan 2.0, into which we can weave in the role of professional bodies and above all, the National Academy of Medical Sciences. My third suggestion for the task force is to create hospital managers for district hospitals. Hospitals cannot be run by common sense by clinicians. No, the time has come that our hospitals are run professionally, and that's about supporting the hospital management systems, formal training, other ways of training, using IT, using other systems, best managerial principles. We could have an in-between transition where we bring it out for people who are not necessarily trained as hospital manager, with the objective that eventually every hospital, every district hospital, medical college is run by professional managers. It's about professional management. The time has come that we move in that direction. So you have fourth suggestion. You have built a blueprint for transplant upgrade in transplant, Dr. Sareen, can be implemented. We need about 2 lakh transplants and we do about 15,000. Huge gap. We do 1,000 liver transplants where it should be something like 50,000 potentially. But the issue is we can make changes in the milieu in terms of policy, and very important steps have been taken. It would not take time, but significant steps have been taken in the last 1 year, and we'll do more. Pledging has become much more profuse now. But where is the capacity? Why in the city, sir? Very few hospitals do kidney transplant. I don't want to name the hospitals. What is the hesitation? Is it training? Is it opportunity? Is it the injection of some resources? So let's create a vision that we have 60, let's say modestly, 60 new renal and liver transplant centers, renal/liver, let's say, in the country within the next 3 to 4 years. And what will it take? Let's work in that direction. Specifically, put the minds together, and we'll be there to support for resources, to make a case for resources. And we will reach out to our leaders like the Honorable Lieutenant Governor to see how at the state level, the UT level, action can be taken. And my last suggestion for task force is reimagining medical education further down. We want next generation, thinking about next generation reforms. NMC has been a reform. A period from MCI to BOG to NMC has moved the clock, moved the needle to some extent, but then we have a real need for now thinking more about it. I can only give a few examples. One, faculty shortages are not going to be met very soon. We talked about specialists being the gap that we talked about. And so you need a specialist, then become a teacher is another journey. How can we help this process? You have emeritus professors, 25,000 of us. Can we contribute in a certain way on the ground, in a systematic way? Then pedagogy needs to now become a blended pedagogy with students choosing to read materials on the net. We have to simply accept it. So that's the way students are now learning. We are slow in understanding how our role should change in a certain way to make the best of it. Now, how do we crack? I have no idea at the moment. Let's talk about it, because it cannot just go on. We think we are teaching in the classrooms, but students are not coming to classrooms in most medical colleges, and they are learning on their own. How can this be blended? So I think next gen medical education, pedagogy and beyond, assessment, competence, concerns about their clinical skills, can we start talking about and then use the NMC platform for the reform? My last suggestion is not for task force, but for partnership and engagement. My request to NAMS and Dr. Digambarji, particularly for yourself, is that let's work also systematically with our nursing colleagues. Our nursing standards, nursing quality, nursing super specialization needs help from all of us, from policy enablers to the people and to co-professionals like us. I urge you that in this journey for excellence, for health sciences, healthcare, and health system, it'll be most apt to work together with nursing associations, in particular, maybe through an MOU that Trained Nurses Association of India and others, that we need to partner with them for ensuring that as we move toward a more ideal healthcare system, our nursing does not lag behind. They would be very much benefited by the support that medical profession can. In any case, they are not different. They're part of our team always, but I don't see them here. So I would urge that we work, take them along, and that will give them a boost of energy, ideas, and working together for the better care of the people of India. I applaud the work that has been done. NAMS has a future, a great potential. It has a great legacy. And let's look at suggestions that come from young people. I have given some submission for a few of action points. Thank you for the opportunity.